All right, guys, welcome back. DENT 3500. Today we're going to be talking about surgical extractions. Now, surgical extractions are an important part of basic oral surgery care. Um, shouldn't be looked at as a failure to be able to get it out in a closed fashion. In fact, it's often the judgment call of the experienced practitioner to switch to a surgical extraction sooner rather than later, instead of putting so much force on the tooth that the crown busts off and then deciding, oh, time to go surgical um, as you develop your clinical sense and being able to see predictors that it's going to be a difficult tooth. Most teeth you certainly will try in a closed extraction format, but certainly some clinically and radiographically right off the hopper, you'll be able to say, you know what, this is going to benefit from a surgical approach, often using the divide and conquer approach, which often leads to a better patient experience if you switch to this sooner rather than later, as it decreases the amount of force that you need to use to remove the tooth and improve the patient experience. Surgical extractions are required less common in the young patients compared to older patients for all sorts of reasons. Often older patients have more dense bone, less PDL space, more complete root formation, and often the teeth are more heavily restored, either root canaled, um, have basic restorations on them, or even crowns, make them more prone to crumble and less likely to come out in a closed fashion. It's a great opportunity to do some surgical extractions in the oral surgery clinic. Often we will show you the first time how to use the 701 burr um, in order to facilitate proper use. But certainly down at the oral surgery clinic, if you've been shown once, make sure you let your instructor know that you've sort of been shown and you want to have a go. It's very important to have this basic skill before you go out in the real world to be able to provide surgical extractions to your patients. In order to do surgical extractions, often you will need to be able to raise a mucoperiosteal flap, and we'll talk about how to do that in this lecture. By switching to a surgical technique, you can prevent situations such as this, where you use excessive force and the teeth come out more of an dentoalveolar fracture style instead of expanding the alveolus and PDL space and sliding the tooth out. Here you see a wide selection of teeth with large chunks of bone connected to them. Even using a surgical technique, certainly depending on the age and the anatomy of the tooth, and sometimes a bit of bone is still going to come out with the tooth, but often with the surgical technique used earlier rather than later in the process, you can actually preserve bone, which might be counterintuitive. You think, oh, you're drilling it away, but actually you're destabilizing the tooth in a precise surgical fashion, thereby saving larger amounts of bone by preventing huge chunks from breaking away with a tooth of interest. So which teeth benefit from surgical extraction? Potentially any tooth, depending on how it's going. But certainly if the patient, I say, is older, is a bruxer with dense bone, radiographically the teeth have really long roots or unfavorable root configuration, i.e. curves, dilacerations, twists. If it's heavily restored or endo treated teeth, heavy restoration and endo treated teeth, it certainly would often try and see if it wants to come out with a closed technique. And this will come with experience to see, oh yeah, it's starting to move, we're going to stick with this, as opposed to, this feels like the tooth is in cement, let's just switch to a flap and a surgical extraction to make everybody's day easier. Here you can see a tooth and dense bone with, which is difficult to tell radiographically, but certainly one thing you can tell from this is that there's very minimal PDL space. Long, slow curve to the roots would potentially come out with a closed technique, but low threshold to switch to a surgical extraction in this case. Also because the adjacent teeth are heavily restored, you're not going to be able to elevate much, if at all, in a case like this, really putting you behind the eight ball, making it more likely that this tooth would benefit from surgical extraction, flat segmentalization, dividing and conquering, and just decreasing the amount of pressure that you need to put on the tooth in order to get it out. Hypercementosis, you certainly see this all the time in older patients. Almost definitely have to do surgical extraction. The whole round peg square hole phenomena. This is going to require flap bone removal down to the height of the expansion in the hypercementotic area in order to remove it. So this is the type of thing on presentation in the oral surgery clinic. I'm going to want to hear that the plan is surgical extraction. There's just no way using basic physics that the root system you can see in this x-ray is going to come out through the opening in the alveolus at the level of the CEJ. Once again, square peg round hole, just not going to happen. You're going to do everybody a service if you remove the crown and segmentalize the roots so they can be removed one at a time. Significant curvature, dilaceration. This is a tooth that is likely going to need surgical help in order to remove it. Certainly every now and then you'll get lucky depending on the age of the patient and it will slip out to everyone's amazement. Once again, low threshold to do a surgical removal in order to get at the very least, the root tip portion out. Teeth that are close to the sinus, a bit controversial. Sometimes if it wiggles out easily, then you can leave that thin layer of bone between the roots and the sinus intact compared to committing to a surgical extraction. So this would be the type of tooth I would certainly give a try in a closed fashion, the upper molar here, and if it wanted to come easy, fantastic. And if it didn't, once again, converting to surgical. And that's going to be that clinical judgment that comes with experience, and that's why you need to do some of these in clinic. Another example of a tooth that's likely going to need surgical extraction. Might not, but based on that dilaceration, curvature of the roots, and the heavily restored crown, very significant chance this is going to need three-corner flap. Take off the crown, segmentalize the roots, take out the mesial and then the distal, wash it out, and close it up. Flaps are an important part of surgical extractions. Early on, they can be a bit daunting, just like anything you haven't done. And there's some basic principles that if you stick by, they're really not that complicated. In general, the flap is outlined by your surgical incision with the number 15 blade. The flap is meant to carry its own blood supply from the base, and it allows you to access the underlying tissues. Sometimes it just gives you a much better view of what it is you're trying to do once you reflect back the flap, and you can actually see what's left of the tooth with direct visualization. And like anything, once you see what you can do, it's often easier to carry it out. At the end of the day, you're going to put that mucoperiosteal flap typically right back where it came from. And this can be maintained by sutures and expected to heal fairly quickly. Using plain gut 3/0 suture will be your bread and butter suture. Rarely, depending on the indication for a mucoperiosteal flap, if I'm using it for implant and bone grafting, I'll use a longer lasting suture like a chromic gut. In order for the blood supply to be preserved to the flap tip, the base must be broader than the free margin edge. And you're going to typically want a bigger flap, not a smaller flap, to allow sufficient access to the area that you're trying to see. Not only to be able to visualize it, but also to be able to access it with your instrumentation. So when in doubt, a little bit larger flap is typically better than a small flap that you're putting tension on and tearing. So just an example of a flap that's correct versus one that's incorrect. As you can see, the one on the left in A, the base of the flap is broader than the marginal edge of the flap. As opposed to B, you can see it's undercut. So those tips are at risk of necrosis in example B due to decreased blood supply. This would be an example of a four-corner flap. Often when you're doing your first flap, you're so excited that you're doing a surgical extraction, you're heavily focused on using the surgical drill and drilling away bone, that you're not thinking a whole lot about your flap. It's almost a means to an end. But certainly, when you're reflecting your flap, you want to be gentle with those soft tissues and rest your retractor, typically a Bishop's retractor or a Minnesota, against the bone, as opposed to against the soft tissues, crushing your flap, or putting constant tension on your flap. So if you just rest the tip of your retractor against the bone, the flap shouldn't be under any tension, which will increase the speed with which it heals. Once again, bigger flap is better. The tissue heals across the incision, so a longer incision isn't going to take any longer to heal as far as number of days compared to a short incision. So when in doubt, make a bigger flap. It's going to give you better access. It's going to heal just as quick, and you're less likely to put tension on it, tearing the tissues. In general, when you're outlining your flap with your 15 blade, and dissecting under it with your periosteal elevator, there's certain things you want to avoid. So in the maxilla, it's pretty straightforward. Your flaps are typically going to be on the facial aspect. The only real foramen of interest on the facial aspect is the infraorbital foramen. If you're dissecting up that far, you've gone way too far. That's something we would do for Lefort osteotomy. It certainly has no role in denoalveolar surgery. So the maxilla is pretty straightforward, fairly forgiving. In the mandible, a little more tricky. You have your mental foramen, so you never want to do a releasing incision in the area of the mental foramen. So typically between the canine and the 6 is a no-fly zone, so no releasing incisions. All releasing incisions should be either anterior or posterior to that. And typically your releasing incisions are going to be posterior in the 6 region. Once you want it to be over intact bone, so when you're back in the molar region, say in the 7, you want to do your releasing incision over that buccal shelf. You don't want to go straight out distal to the 7 because you'll plunge off the bone into the lateral pharyngeal area, which unfortunately is right where your lingual nerve runs, along that lingual aspect of the mandible. So you always want to do your incisions over intact bone. Don't do any releasing incisions in the area of the mental foramen or in the area of the lingual nerves. So different types of flaps. The simplest one is a simple envelope flap. The next most common would be a 3-corner flap, followed by a 4-corner flap. And it's going to be based on the access that you require. For myself, the 3-corner flap would probably be the flap I use 80 to 90% of the time. Envelope flaps don't afford you a whole lot of access. So when I've decided I want access, I want good access. So I typically go right to a 3-corner flap. Doesn't mean there's no role for an envelope flap. It's just in my hands, when I've decided I want a flap, I want more access, not less, so I'm going to a 3-corner. And rare for me to require a 4-corner flap. Certainly if I'm doing something bigger like a sinus lift, I'll absolutely use a 4-corner flap if and when I need to, but the 3-corner flap is your workhorse with respect to access to surgical extractions. When you're doing an envelope flap, you're essentially, there's no release incision. You just do a 15 blade incision in the sulcus, typically 2 teeth anterior and 1 tooth posterior to the area of interest. So say you were struggling with a upper 5, you would do a sulcular incision with your 15 blade going in the sulcus of the 6, the 5, which is the tooth of interest, and then 2 more teeth in front of that, so the 4 and the 3. And this would give you a big broad opening to be able to dissect in the subperiosteal fashion to retract back that gingiva to get some access. 3-corner flap, like I mentioned, kind of my workhorse. Nicer because you certainly get more access, and you don't need to do your sulcular incision as many teeth in front of the area of interest. Typically just 1 tooth in front, 1 tooth behind, and then you can drop your releasing incision typically posterior to the area of interest. That way, as it heals, there's not sutures anterior that are visible or a little scar line that's going to be visible to the patient down the road. So typically I hide my releasing incision at the posterior aspect of my three-corner flap, unlike what's seen in a lot of the photos in your textbook. So here you can see a cartoon example of a envelope flap in example A. So 2 teeth in front and 1 tooth behind the area of interest. Given that sort of broad access to the area of interest, looks nicer here than it does in real life, to be honest. And I say typically in my hands, if I need to do some drilling around the tooth, I'll do a 3-corner flap, which is what they're showing in B. Like I mentioned, in B, they're showing the releasing incision anterior. So 1, 2, 3 corners. Hopefully you can sort of pick them all out there. But with the releasing incision is anterior in the area of the canine. I don't like that. I would have my sulcular incision in the exact same spot, and my releasing incision would be posterior. That way your sutures to close up that corner of the flap are more towards the back of the mouth, more comfortable for the patient, and you don't have an incision line going up in the aesthetic zone. So here you can see the 3 corners of the 3-corner flap, showing it dissected in a subperiosteal fashion, giving great access to the area of interest. In this case, it would be the 5. Very rare to need a palatal flap. That would be more in keeping with periodontal surgery or cleft lip and palate repair. For your purposes, you typically will never need to do a palatal flap, and certainly don't need any releases in that area because there are other foramina in there, nasopalatine and greater palatine, carrying their associated neurovascular bundles, which need to be avoided. Your releasing incision is not 90 degrees to the occlusal plane. It's typically oblique, which will allow you to get that nice broad base to keep your flap perfused. But you want to design it so you're not crossing any bony prominences like the canine prominence. It's more likely to slough, to hiss, and come open during the healing process. Just showing some do's and don'ts here. Your releasing incision is typically on the mesiobuccal or distal buccal line angle of the tooth, as opposed to the middle of the tooth. So you see in B they're showing not to do number 2, where the releasing incision is in the middle of the tooth. Typically just doesn't heal as nice, more likely to create an area of recession if you do that. And then in number 1, they don't like that either because it's crossing over the canine prominence. Personally, I say I do my releasing incision posteriorly, and in this case, say we were trying to work on the 5, I would do my releasing incision the distal aspect of the 6, and I would actually do it just distal to the papilla between the 6 and the 7. Nice oblique incision going up, and I'll add it actually as a graphic so you can see it as option number 3, and it just makes it a lot easier to close, because your first stitch, when you go to close that 3-corner flap, you can basically put your stitch right through that papilla and haul the whole flap up by doing it that way, and it's much more user friendly. No matter where you put your releasing incision, you want to make sure that it's away from the area you're about to make a hole. You can just imagine if you're biopsying a cyst or doing sinus lift or drilling at a root, if there's about to be a little crater after you're done your surgery, you don't want the margin of your releasing incision being right on the edge of that crater. It's more likely to open up your incision as it collapses in because it's not supported by sound bone underneath. So just make sure you're thinking one step ahead. Where am I going to be drilling? Let's get one tooth away on either side so that when I go to close up this flap, it's going to be over sound bone. Just like taking out teeth, it's easy as 1, 2, 3. All right, big boy flap, 4-corner flap. I typically will only revert to a 4-corner flap if my 3-corner flap's not giving me what I want. So I go to do procedure in the maxilla called a sinus lift. I'll do my sulcular incision, pop my releasing incision up, distal to the 7, dissect up, and if I feel it's under a bit too much tension, then I'll drop another releasing incision anteriorly, which is creating my fourth corner, which gives you fantastic access to the area that you're working on. It just means that there's more to put back together, more likely to fall apart. So that's why I kind of reserve it for situations when my three-corner flap clinically just isn't giving me the access I want. But just like a close extraction, typically I give the three-corner flap a shot before I upgrade it to a 4. So hopefully everybody can see the 4 corners of this flap. 1, 2, 3, 4 flap development. So typically using a new 15 blade, because if you use a used one, they dull in very quickly. So you want to go in with a new 15 blade. And typically you do your incision back to front. And if you're doing a release, you start apically. So up by the sort of the root tip area, down to bone, bring it up through the unattached into the attached gingiva, up to the sulcus. Take the tip of your blade, run it along the sulcus anteriorly, and then if you're doing another release, then once again you can do your anterior release at that point. But once again, I said the workhorse is my three-corner flap, so I do my release, my sulcular incision, and you do that back to front. And then you typically develop your flap front to back, flipping out the papillas and flipping out the corners and getting in that subperiosteal plane. Sometimes as you're developing it, you can see there's like a little leftover, a little left behind periosteum that you didn't quite get with your 15. Just stop, get your 15 back in there and nip it, and that'll be much better than trying to tug on it and tear it. Important when you're doing the sulcular incision portion to really pay attention to get the tip of the 15 blade right down in that sulcus, right where you do your probing depths. Difference with your probing depths, you're just sort of feeling the junctional epithelium at the bottom. With the sulcular incision, you're putting that tip of the 15 blade in until you feel that crustal bone. And you really got to take your time, make sure you don't slip, make sure you're through periosteum right down to crustal bone the whole way. It's really going to serve you well when you go to use your periosteal elevator and develop that flap if you've done nice clean incisions. I don't want to see people leaving any epithelium behind, sloppy incisions, sloppy sulcular incisions. You want to be very precise, take your time, and make sure that you're right between that tooth and that marginal epithelium when you're making that sulcular incision. Here you can see the beginnings of a three-cornered flap. Looks like this is being used to remove lower partially erupted third molar. So as you'll note, the Bishop's is in there creating nice taut tissues to allow the 15 blade to make a clean incision. And notice how the incision is distal buccal to the lower molar, not straight at the back, because if you look at the dry skull and the anatomy of the mandible, it actually flares out significantly there. So this incision is in a nice safe place, distal buccal to the last molar, over that buccal shelf, well away from that lingual nerve. Here you can see a okay three-corner flap with the Bishop's sitting between the bone and the mucoperiosteal flap, and you can just see how that releasing incision gives you fantastic access to that entire buccal shelf if you want to do anything in that region. Your periosteal elevator has two ends. Typically at the beginning of flap development you want to use your pointy end because it's easier to flip out the papillas in the corners of the flap, and also you can use it for any areas that are a little bit deficient in an incising fashion. But once again, if it's tugging a little bit too much, just stop what you're doing, visualize the area that needs to be re-incised, and use your 15, and then go back to your pointy end of your periosteal. Once you get it going, you can switch over to the broad end, and it will try to move along fairly quickly. Certainly getting it going at the beginning is the delicate, tricky part, where you're trying not to tear that precious attached gingiva. And then once you get past that mucogingival junction, I said you can usually develop it quite rapidly with the broad end of your periosteal elevator. If you just do a sulcular incision, you typically just need to put all the papilla back. Make sure you put each and every one back. Don't put one or two. If you've developed 4 or 5 papilla and say, it seems to be holding all right, you don't want your flap to slough off. If you've done a releasing incision, say a 3-corner flap, you put the corner of your flap back first. That's your first stitch. Then you can go ahead and put the ones at the level of the alveolus back. And then last but not least, you can put 1 or 2 in your releasing incision. So just showing the first stitches at that corner of your releasing incision. This is the most important stitch from wound integrity, and also it ensures that you're able to line this corner up perfectly. If you put sutures in the 2, 3, or the 4 position earlier, you could accidentally steal tissue away towards the area you're suturing, and then when you go to do that corner at the number 1 site, because it's already been tethered down with some previous sutures, it may hinder your ability to line up that junction perfectly like you want to. Surgical extractions. So sometimes surgical extractions can simply be developing a flap to get a better look at what you're doing, and then not necessarily drilling any bone away, but by being able to visualize the tooth that was perhaps fractured off or had deep caries in a subgingival. When you reflect it back, you can actually see, what's left of the tooth better, and allow you to position your forceps on what's left better. Sometimes you can sneak down depending on the location and indication, and take a mil or two of that crustal bone with what's left of the tooth. If it's thin, allowing you to get a good grip on the tooth and wiggle out what's left of it. More commonly, if I'm raising a flap, I'm doing something like this. I've committed that it's not coming out easily. I want to get a good look at where the bone meets the tooth, and I want to drill in that PDL space. You want to make sure you're drilling in that PDL space, not taking a ton of tooth away, because a lot of these teeth, if you took a 701 burr's width of tooth away, it wouldn't be leaving you much with left to work with. Yeah, and you would end up breaking off what's left, and you're right back to the drawing board, having to drill even more away. When you're using the 701, you typically want to make a real nice slot. You guys are all very capable of doing this. If you can do a crown prep, you can use a 701 burr and do a surgical extraction. You want to make a nice fine slot, because by doing so, it allows you to put your elevator down in that little slot you created, and actually elevate between the bone and the tooth or root that's left, and really kind of get it rocking back and forth before you wiggle it out. The only thing holding the tooth in is bone and PDL. So by removing it, you're swaying things in your favor. Say typically elevating it back and forth to the point that you can tell it's ready to go, and then you can sneak in with a mosquito or a forceps and pluck it out. The most common area of error is people are too conservative. They only remove like a little millimeter of bone, and fair enough, they're trying to be conservative, but at this point you've flapped it, you've committed to a surgical extraction. You want to get it out. You don't want it to take 3 hours. So you want to make sure you remove about a half to 2/3 of the length of the root. Typically a good marker is the 701 burr itself. The tines are about 2.5 to 3 millimeters long, and if you go down sort of the length of that 701 burr, parallel with the long axis of the tooth, so you're not accidentally cutting into the neighbors, you'll make significant gains with respect to swaying things in your favor, a nice slot to elevate against, and things are often night and day easier with respect to getting the tooth out. When you're dealing with multi-rooted teeth, so the molars, typically want to divide and conquer with lower molars. You typically just split it right through the furcation. So then you're essentially left with two little teeth, which is much easier to deal with. The maxilla, you want to divide it to accommodate the three roots. So you'll section the palatal root off, and then you'll section the mesial buccal from the distal buccal. So here you can see sectioning of this tooth right through the furcation in a buccolingual fashion for lower molar, and then you treat each of them like individual teeth, and they often come way easier now that you've separated the two roots from one another. Here you can see a nice example of surgical extraction using what looks like a three-corner flap, so a distal buccal released through the attached gingiva, and then the incision extends from the sulcus. Mesial to this molar is, there's normally obviously a tooth there, so normally that would be a sulcular incision, but you'll see in a video that I'll post that had a similar situation where you just extend the incision along the ridge in the edentulous space anterior to it. Still a three-corner flap in that scenario. A little buccal trough to help destabilize the tooth. Lots of bone on that buccal shelf, so a great place to make a nice trough, allowing you to see the furcation. And then you can really use, say, 701 or number 8 round. Typically I use a 701 because it's a little more precise to section that tooth along its long axis right down through the furcation. You want to make sure you get 100% or at least 90% of the way through, so there's very little tooth structure remaining connected to itself. And then you can go in with a 77R, and I'll tell the patient you're going to hear a little click. And then by rotating the 77R, you just separate that last little shell of enamel or cementum that was connecting the mesial to the distal. You want to visualize that as you're elevating in that little slot you made, you can appreciate that the mesial and the distal are moving independent from one another, and then you proceed and wiggle them out just like they're little incisors. Just like I mentioned in the previous video, you treat each one like they're its own single-rooted tooth. On the left, you can see it looks like they're using a 151 forceps to remove the mesial, followed by the distal. And on the right, you can see the flaps put back together in the tooth. She gone. Very common situation with maxillary molars to either crack the crown off or surgically remove it, or the patient comes in and the crown has cracked off on its own and you're just left with a three-rooted system that's all fused together, typically at the level of the CEJ. So you want to use your 701, so access the tooth first, typically with the three-corner flap. In this scenario, I would do a little distal release up, distal to that 7. Just much nicer access in my hands. And then you want to segmentalize it. So you want to separate that palatal from the mesial buccal from the distal buccal. So typically you make a little Mercedes-Benz symbol in the tooth and you're off to the races. Then you can do mesial buccal, distal buccal, take out palatal last. Often you'll do it in that sequence, but certainly you'll take out whichever one wants to come first, but it's good to have a plan. And sometimes one of these will break, so maybe you'll get mesial buccal out, you'll get palatal out, and distal buccal cracks off. Then you have to chase after it. It's not a big deal. It's not a failure. It's par for the course. It's part of surgically extracting teeth. Typically when I'm extracting these teeth, you really want to make sure you get things moving before you attempt to pluck them out. So the mesial buccal and distal buccal, you really want to see it moving back and forth really nicely. And then often you can use your periosteal elevator or your 77R to elevate it right out of there. The palatal is a different story. It's typically your last man standing, and you typically go in there with something like a 76S and treat it like a single-rooted tooth and reach up there, grab it with your forceps, and rotate it until it comes out. Roots, when you're starting off extracting teeth, can be very daunting. You're extracting it and you're like, oh, I just hope this doesn't crack, or I hope it didn't get a root tip, or you'll be in denial and you're like, oh, I think I got it all. You got to check the end of your tooth after you've gotten it out. Is it nice and smooth or is it not? And if it's not, there's a root tip up there. Step one, you got to see it. So you got to have good light. You got to irrigate the socket out, suction, and good access. If you can't see it, maybe you need to do a flap, maybe you need to do bone removal, maybe you need a mirror, but you got to be able to see what you're doing, and that requires good coordination with the assistant so that they um, are in and out with the suction, allowing you to work at times when they're out of the way, and you need to be coordinated so that they're going in every 3 to 5 seconds to suction, whether you ask for it or not. Because if you have to say, yeah, suction every 3 to 5 seconds, it gets really old really quick. Not that complicated. Pretty much every root tip can be removed by going around it with a 701 burr, putting a very fine instrument, also known as a root pick tip, in that little space that you created and teasing it out. It really is as simple as that. I think people overcomplicate it. They get worried about it. They don't want anything to do with it, and they are kind of really scared of this happening. It's not a complication. It's par for the course of taking teeth out. As you get better, you absolutely have less root tip fractures, but certainly some teeth, no matter how appropriate your technique is, will have root tip fractures. So you got to have a plan. Not all root tip picks are created equal, so if you call for one and you're like, this is just too stinking big, ask for a different one. They're all different shapes and sizes, and typically the finer, the better. If there's a little space between the root tip and the bone, then you can sneak down in it. At the end of the day, you got to get some type of force on that root tip that is sort of coronal in nature, that's going to bring that root tip out of the socket. The last thing you want to do is go in there blind or go in there with an instrument that's too big and actually push up apically on the remaining root tip, because it will either go back into hiding further up the socket, or even worse, go somewhere else, get displaced into the sinus, submandibular space, inferior alveolar canal. So you got to be very precise with this. Some people have tried, and certainly successfully, using things like endo files. Typically not needed. This is getting a little too fancy in my mind. Once again, get a little purchase with a very fine root pick tip. If you need a little tiny slot, make one. This puts you at risk of displacing it. In order to get that endo file in there, you need to put apical pressure on that. And I really don't like the idea of that, because I've certainly seen root tips disappear into places you don't want them to go. And it starts with inappropriate apical force on it. Once again, there's not a single root tip out there that can't be removed with the 701 and root pick tip. I remember being in your shoes in oral surgery. Jeff Watson, oral surgeon in Fredericton, came in to help me. I fractured off. It was a 4-5. I remember it like it was yesterday. And I was like, throwing the towel in. Yeah, this is toast. Came in, grabbed the 701 bar, zip, round he went with it. Put the elevator in and popped it out. And I remember it was like a little aha moment. I'm like, that's easy. I can do that. And never looked back. If you do that and the remaining root cracks off, guess what? Right back where you started, 701 burr. Make a new little trough, and you just keep working your way up the root. Eventually, you'll get to the tip, which you don't want to. Typically, you want that tip to come out nice and clean. It's very satisfying. You want to preserve as much bone as possible. But point is, if it cracks, just pick up where you left off, make a new slot, and start elevating. When I'm doing this, typically in the maxilla, in the aesthetic zone, I will typically remove the bone from the palatal aspect and interproximal, and not come out to the buccal if the buccal wall is thin. That way you don't lose your buccal wall. I typically assume that every patient is going to want to go on to have an implant, so I do everything I can to preserve as much bone as possible in doing so. So typically I won't go around the facial aspect in the aesthetic zone to try and keep that buccal plate for down the road. Typically, if I can see a root, I'm taking it out. But there is certainly a list of indications that you may consider leaving it. But once again, if I can see it, I'm going to take it. The odd time I'll elect to leave it is if the risks outweigh the benefits. So if it's close to inferior alveolar nerve, and I'm concerned that I'm going to damage that by picking away at it, and it's small, so less than 4 millimeters, and not associated with a necrotic tooth, um, then I'll consider leaving it in that very rare instance. Um, Once again, only if I can't see it. If I can see it, then typically I can tease it out in an atraumatic fashion. In the rare event that I did leave it, I would certainly inform the patient, explain why, and typically document it with a post-op x-ray just to make sure I am not being fooled with how big the remaining root tip is. If it turns out that you were fooled, it was bigger, then go back and get it. Patient's still in the clinic, they're still frozen. Now's the time to do it. Okay, guys, little demonstration of a 3/7 surgical extraction using a 3-corner flap. Get in there with your number 9 periosteal elevator, 77R, lone standing tooth, not much to elevate on. Still trying to keep it a closed extraction technique using my cow horn, seating the lingual beak, trying to get in that furcation, followed by the buccal beak. Just wasn't getting in there due to the extensive caries, and I could appreciate that. So instead of trying to stick with it, we move on to a surgical extraction, which is a more appropriate plan, more predictable. Here we see our distal release going distal buccal over that buccal shelf. Sulcular incision right in that sulcus. Notice how we start at the back, and then we work our way anteriorly. Here we do a little crestal incision, then I extend my crestal incision a little bit, right up to the distal of that 5, just to give myself a nice broad flap. Then using the pointy end of the periosteal elevator, we develop that flap, typically front to back. Once we're in that subperiosteal plane, it develops quite nicely, and we can get our bishop's retractor in there. At this point, we take our 8 round and develop a nice buccal trough, which will allow us to destabilize the tooth. You see, the only thing holding it in is bone, PDL. So take some bone away. Lots of bone to give on this buccal shelf. And it allows us to get a good look at the anatomy of the roots, the furcation. You can just do a buccolingual segmentalization like in the cartoon, but it's a long way to go all the way through the crown and then down through the furcation. So often more and more, I'll just take my 701 burr and just quickly lop the crown off, and that gives you access to the roots. And makes it a lot easier, I find. So I'll do the same thing on maxillary molars, just lop the crown off at the CEJ. Basically get most of the way through. And then that last little bit, you use your 77R. Notice I'm putting a gauze in there just to make sure the patient doesn't aspirate the tooth. And either put a finger or the suction on a cusp of the tooth so it doesn't go flying. Crack the crown off, remove it with a mosquito, and now you're just left with the root system. So a much more predictable situation. You really appreciate we're right in the pulp chamber there, so we're just using the 701 to cleanly segmentalize in a buccolingual fashion. I say you could do this with the crown on, it's just harder to see that furcation coming down with the crown on compared to with the crown essentially out of the way. And then running that 701 burr around both the mesial and the distal roots, really making sure, see them the whole depth of the 701 burr. And then I'll get in there with the 77R to make sure that they're moving independent of one another. Really take my time, make a nice clean slot. Making sure we got 2 separate roots here, so we're going to treat them as 2 separate teeth. Just showing off my handiwork here, knowing that this lecture was coming down the pipe in a asynchronous fashion. We're really trying to optimize some of these things like this video, which we didn't have in the past. So great option. Letting the roots talk to me. Mesial 1 says he wants to come, so out it comes. 77R using that slot I made. So this is a tooth that went from not wanting to come out with a forceps to coming out pretty easy when we go surgical. So mesial root out. Distal root, a little more stuck in there. If it popped right out with the 77R, we'd be done now. Just didn't really want to. Comes here to work out a little harder on the distal and then finish it off with the mosquito. Very important after a surgical extraction to wash it all out. Big wash under that flap. We want to get down on the socket, but also where that subperiosteal plane to get all the bone dust out of there, minimize the likelihood of infection. Putting our flap back, 3-corner flap, so we're doing that corner, the distal corner first of our 3-corner flap, right where it used to meet the distal buccal line angle of that 3-7. So tacking that back, that way we know that the flap is back in its proper orientation, front back. Most important suture of the flap is this one right here. That will resuspend the whole thing and make sure that we're not stealing tissue away anteriorly or posteriorly. Once the corner's tacked, then we can do our sulcular incision, or in this case our alveolar ridge incision. And then last but not least, we can do our distal release. After you've done the corner, it's not super important which sequence you do them in, but the most important one is getting that corner done first. So lots of interrupted plain gut 3/0 sutures. You can see the whole flap's resuspended, washed out nicely, tooth gone. Everybody's happy.